This is a 24/7nursetutors.com lecture. 24/7 Nurse Tutors, providing unlimited tutoring.
Welcome, and thank you for joining us. Respiratory System, Part 2.
I remember going into the ICU and seeing a patient in pulmonary edema and thinking, oh my. He made me see pulmonary edema in a different way. Hey, it's like drowning in your own fluid. Every time he spoke, he sounded like he was gurgling. He had peripheral cyanosis and was not doing good. He had pulmonary edema brought on by congestive heart failure. It was sad. Pulmonary edema is a life-threatening condition. It's characterized by a rapid shift of fluid from plasma into the pulmonary interstitial tissue and the alveoli. This results in a markedly impaired gas exchange. It can result from a severe left ventricle failure, rapid administration of IV fluids, inhalation of noxious gases, or opiate or barbiturate overdose. Rapid fluid accumulation in lung spaces that has leaked from engorged pulmonary capillaries. The most common cause is sudden deterioration of left ventricle function. Fluid backs up into the veins of the lungs. Increased pressure in these veins force fluid out of the vein and into the air spaces, the alveoli. This interferes with the exchange of oxygen and carbon dioxide in the alveoli. The symptoms of pulmonary edema are as follows. There's an extreme shortness of breath, which leads to a severe difficulty in breathing. A feeling of air hunger or drowning. Many times there's a grunting sounds with breathing. The patient may have an inability to lie down. Other symptoms include rales, wheezing, and anxiety. Other symptoms of pulmonary edema include restlessness, cough, excessive sweating, pale skin, nasal flaring. The patient often coughs up blood, and breathing is temporarily absent. Your nursing interventions for a patient who is in pulmonary edema include administering oxygen to relieve hypoxia and dyspnea, assess breath sounds and monitor respirations, the pulmonary artery catheter. Be sure to keep the patient in high Fowler's position, urinary catheterization. You will also monitor the patient when they are on CPAP or PEEP. What is CPAP? Well, it's a continuous positive airway pressure, and it serves to keep the alveoli from collapsing, resulting in better oxygenation and less work of breath. The CPAP mode is very commonly used as a mode to evaluate the patient's readiness for extubation. What is PEEP? Well, that's positive end expiratory pressure. It's the amount of pressure remaining in the lung at the end of the expiratory phase. It is utilized to keep otherwise collapsing lung units open, while hopefully also improving oxygenation. So let's talk about asthma. Let's discuss a few more things about asthma. We do know it's a reversible disease. We have narrowed and inflamed airways. Different things can trigger asthma, like allergens, irritants, even cold air, exercise, respiratory infection, emotional stress, and beta blockers. Let's discuss chronic airflow limitation. In asthma, the occurrence is more in males than females. The patient has hypersensitivity. The onset is usually before the age of 12. Symptoms include hypoxemia, which is tachycardia, increased restlessness, tachypnea, the retractions and prolonged expirations. Now, this is an emergency situation. If symptoms do not respond to usual treatment in 30 minutes, clients should seek medical attention. You'll notice elevated carbon dioxide retention, a cough, raised mucus, and expiratory wheezes. Status asthmaticus is now called acute severe asthma, and it is, again, a medical emergency. It is severe, life-threatening. It's an attack where the asthma does not respond to treatment. We are giving all the usual treatment, and the patient is getting worse. Now that's scary. Did you know medications can cause asthma? Beta blockers, those end in LOL. Remember, for NCLEX, learn the classifications of medications. I've seen students trying to learn the different medications. You will never catch up. Don't do that. There is a way you can learn each med, know the classifications, and their general side effects. Example, we all know beta blockers end in LOL. So if you see metoprolol, guess what? It's a beta blocker. What happens with most students is they go into the NCLEX and see a medication that they have never heard of before, and it throws them into a big panic. You need to know the classification. Don't try to memorize all of the drugs you have never known. It is not possible. And most importantly, you are not studying to be a pharmacist. So please just know the classifications and know their side effects. Stick to the classifications. Here's an easy way to solve this. If you see Mumalol, guess what? It's a beta blocker. If you see Daddy Law, Cousin Law, Sister Law, Brother Law, I don't care which law it is. Class, you're not going to a pharmacy exam, so guess what? It's a beta blocker. So we know a beta blocker ends in LOL. What about ACE inhibitors? What do they end in? Pril. It's spelled P-R-I-L. So I don't care which Pril it is, pick ACE inhibitors. Did you know there are certain people we have to be really, really cautious with, and in some cases, they aren't even allowed to take beta blockers? So number one, we have a hint. Asthma patients. Why do they stay away from beta blockers? Because it causes bronchospasms. Beta blockers causes bronchospasms in patients with asthma or COPD. A patient in second or third degree heart block. Can you tell me what is going to happen? Well, the patient is already in heart block, and then we give him a beta blocker? No. It will make his condition worse. Number three, anyone with Prinzmetal angina. Now write that down. Prinzmetal angina. Why do we need to keep them away from beta blockers? Because beta blockers can cause vasospasms in a patient who has Prinzmetal angina. We are really want to be careful with a patient who has diabetes. Why? Because beta blockers mask the signs and symptoms of hypoglycemia, and we do not want to mask the signs and symptoms of hypoglycemia, do we? No. We also know the beta blockers many times do not work very well with certain ethnic groups. Make a guess which ethnic group this is. Yes, African Americans. They are known to do a lot better on calcium channel blockers. So what are we going to see with a patient that has asthma? Well, we're going to see difficulty breathing, wheezing, and chest tightness. Sometimes the wheezing is so loud you don't even have to osculate to hear it. We know these patients are going to put themselves in the tripod position right away because they are trying to breathe. We want to look at the medication history. We want to assess what caused it. What could we do to make sure it doesn't happen again? Medications that are given to patients who has chronic airflow limitation diseases include corticosteroids, anticholinergic agents, and we all know anticholinergics dry up SLUD. Remember SLUD? Salivation, lacrimation, urination, and defecation. I repeat, anticholinergics dry up salivation, lacrimation, urination, and defecation. Which one do we give first for an asthmatic patient? A corticosteroid or a bronchodilator? I'm sure you said broncho before a corticosteroid. And if you forgot, remember your ABC. A broncho before corticosteroid. This is an ABC problem. We need to give the first broncho to open up the airway before we give a corticosteroid. Remember, ABC. Give a broncho before corticosteroid. Another chronic airflow limitation disease is chronic bronchitis. Another name for chronic bronchitis used around the country is the blue bloater. Now, some of you haven't heard that before, I'm sure. So let's make a guess of what color our patient might be. Yes, he's blue. Your patient is cyanotic, and what does bloated mean? Blue bloater? Well, some students think it's the barrel chest. The barrel chest is with the emphysema patients. Bloated means you feel puffy, you feel full or windy. People describe it in many ways. So why would the patient who has chronic bronchitis be a blue bloater? Because many of them have cor pulmonale. And what is cor pulmonale? It is the right-sided heart failure, and we all know with the right-sided heart failure, they retain what? Right, they retain fluids. They have pitting edema and ascites, probably crackles. They feel bloated. That's where the name comes from, blue bloater. Chronic bronchitis is usually diagnosed when a patient or a client is daily productive coughs for at least how many months? 3 months. Very good. And how many years in a row? 2 years. 2 years in a row. Some of the signs and symptoms of the patient who has chronic bronchitis are, in the earliest symptoms, frequent productive cough during the winter, frequent respiratory infections. Other signs include bronchospasm at the end of paroxysms of coughing, a cough, dyspnea on exertion, history of smoking, normal weight or heavy set, a distended neck veins or cor pulmonale, a ruddy or bluish red appearance, polycythemia, and cyanosis. Let's look at our emphysema patient. This is the pink puffer. So class, make a guess what color the patient is. Yes, they are pink, and they have pursed lip breathing. They are non-cyanotic. These patients are usually thin and have a barrel chest because of the trapping air. Emphysema is a disorder that is defined by the anatomical changes that occur in the lung. We talked about that on the first page, didn't we? It involves gradual damage of the lungs, and there's a lot of destruction of the alveoli. Smoking is the #1 cause of emphysema. That's why it is so important for smoking cessation. We need to be careful with patients who have chronic obstructive pulmonary disease, or COPD. How many liters of oxygen can we give our COPD patient? 2 liters nasal cannula. Why? Because of their hypoxic drive to breathe. Most of these patients put themselves in a tripod position. Can you show me the tripod position, please? Get those baseline arterial gases. They are CO with 2 retainers. We want to teach them pursed lip breathing. Teach them the tripod position. For most patients, we don't even need to teach them. They put themselves in that position when they cannot breathe. Atelectasis is a complete or partial collapse of a lobe of the lung, or it could be the whole lung. It is a common respiratory tract disorder associated with immobility and the administration of anesthetic agents. Clients who are at risk are encouraged to cough and breathe deeply. This will aid in preventing atelectasis. It could be caused by an obstruction, like you can see in A above, or accumulation of fluid or air, like you can see in B. An incentive spirometry is a device which encourages deep breathing. It prevents and treats atelectasis. Depending on the unit you may work as a new nurse, you will probably be teaching a lot of patients how to use an incentive spirometry. So, what will you tell them? What will you tell them to do? We want them sitting upright if possible. Hold the incentive spirometer in an upright position. Place the mouthpiece in your mouth and seal your lips tightly around it. Breathe in slowly and as deeply as possible. Notice the yellow piston rising toward the top of the column. The yellow indicator should reach the blue outlined area. Hold your breath as long as possible. Then exhale slowly and allow the piston to fall into the bottom of the column. Rest for a few seconds and repeat steps 1 to 5 for at least 10 times every hour. How often should they use their incentive spirometry? Yes, 10 times in 1 hour. After each set of 10 deep breaths, we ask the patient to cough to be sure their lungs are clear. If the patient has an incision, remind them to splint when coughing by placing a pillow firmly against the incision. Let's talk about another important device you may come across in the clinical setting: chest tubes. What is a chest tube? I'm sure your teacher told you chest tubes are used to remove pus, fluid, and air. Remember what I told you to know for your medical emergencies for NCLEX. This way you will keep your patient safe, right? Right. A chest tube has 3 chambers: the collection chamber, the water seal, and the suction chamber. So what do we do with the collection chamber? Well, this chamber collects. It collects all the fluid coming from your patient. You write on it, say, every 3 hours. So you go in at 9 a.m. You initial it and write 9 a.m. where you see the exudate stop. This chamber allows us to see how much fluid is coming from our patient. Is it excessive or just right? What does it look like? We all know that you don't want your tubing to be kinked. It's very important that you make sure the chest tube is below the insertion site. It has a floor stand, or you can hang it on an immovable part of the bed, okay? Make sure it's not kinked. Make sure it's flowing well, and keep an eye on the water seal chamber. We have an air leak monitor. Can you see it at the left bottom hand corner of your video? The air leak monitor will tell us if we have an air leak, and if we do, remember to begin checking from the patient all the way down. Chest tubes are used to remove pus, fluid, and air. A chest tube has a collection chamber, a water seal, and a suction chamber. The first 3 hours after insertion of a chest tube, 300 milliliters of fluid is normal, okay? That's normal. Now, if we have more than 500 mils in 24 hours, we need to notify a healthcare provider or physician. we may have a problem. So once you put that tube in, guess what? Yes, fluid is going to gush out. With the mediastinal chest tube, that fluid should not exceed 500 to 1,000 milliliters in the first 24 hours. The water seal chamber prevents backflow and acts as a one-way valve. Remember this, class. This is how I teach water seal chamber. Guess what you see when you go to the beach? You see waves. And waves remind me of tidalling. In the water seal chamber, we see tidalling. When a patient breathes in, it goes up. When they breathe out, it goes down. That's what happens in the water seal chamber. Tell me, if you open a can of food like Campbell's soup, right? And you see continuous bubbling coming from the can of soup, are you going to eat it? Well, I hope not. Why? Because, and this is very important, it was a sealed can of food. So you should not expect to see any bubbling coming from a sealed container, right? Let's continue talking about the water seal chamber. Now, this prevents backflow and acts as a one-way valve. Tidalling is expected. With the suction control chamber, water suction aids in draining air or fluid from the chest. Gentle, continuous bubbling is expected. Once again, gentle, continuous bubbling is expected. Now let's quickly discuss emergencies with chest tubes. Let's say you walk into a room and your confused patient has pulled his chest tube and is holding it in his hands. Sue, I got a flower for you. Now, what are you going to do? I hope you know that this is an emergency. Because an agitated patient may pull the chest tube out of his chest, cover the site with a sterile dressing and tape down only 3 sides. Now, why should we tape down only 3 sides? Right, this will allow air to escape through the 4th side, preventing air accumulation and the risk of tension pneumothorax. Stay with the client while a colleague calls the physician stat and gets the equipment for a new tube placement. Another emergency we could have is if a chest tube disconnects from a closed chest drainage system. Quickly reestablish the water seal. How? You submerge the distal end of the tube in 1 inch of sterile water to create a temporary water seal while you prepare the system for reattachment or replacement. Remember, you are more than a conqueror and you will be successful. Join me as we review core content in the next unit.